Welcome, curious minds, to another deep dive. Today, we're plunging into, well, one of the most intricate and really profound topics, neurogenic communication disorders. Just stop for a moment and consider the sheer complexity of the human brain, right? How it orchestrates every single word you hear, every thought you form, every sentence you speak. It's this silent, incredible symphony happening constantly. But what happens when that symphony is disrupted? Imagine trying to speak, to understand, to read or write when the very foundation of those abilities is deeply challenged.
It's a profound question, isn't it? Communication is so fundamental to our human experience, something we often take for granted. And when it's impacted by neurological conditions, the ripple effect on an individual's life and, on their families, it's just immense. It truly underscores how much we rely on these often invisible brain functions.
Absolutely. So our mission for you today is to give you a clear, accessible shortcut to being well-informed about these complex conditions. We're going to demystify some genuinely dense medical terminology, pull out the most important nuggets of knowledge from a foundational text in this field, and share some surprising facts to keep you hooked. Our goal is to help you connect the dots, understand not just what these conditions are, but why they manifest the way they do, and how dedicated professionals approach assessment and treatment, all without feeling, overwhelmed by information overload.
Yeah, think of us as your guides, kind of helping you navigate this complex territory and really understand the key concepts and their real-world implications. We'll be explaining important terms and concepts from each chapter of our source material, always aiming for simple, clear language.
Okay, so let's unpack this. We're going to start right at the very beginning with the basic building blocks of the nervous system.
The brain's masterpiece, a core understanding of neuroanatomy.
So when we talk about the brain and its incredible role in communication, we really have to begin with its most fundamental unit, the neuron. For those of us who might need a quick refresher, what exactly is a neuron and what makes it so special, in the context of the nervous system?
Well, at its core, a neuron, or a nerve cell, is the basic functional unit of the nervous system. Its primary job is communication. Think of it as a microscopic electrical wire, basically, designed to receive input from other neurons and then transmit an output signal. It does this through two main structures. The dendrites, which are like the neuron's branching antenna receiving incoming signals,
Okay.
and the axon, which is a single long cable that transmits signals away from the cell body to other neurons.
That makes perfect sense. And I learned that these axons aren't all created equal, which is quite fascinating, actually.
They certainly aren't. Axons vary greatly in both length and diameter, and these variations have a really significant impact on how quickly information travels. Most are only a few millimeters long, connecting nearby brain regions. But some, like those carrying signals from your brain all the way down to your lower spinal cord, can actually be several feet long.
Wow.
Yeah. And here's where it gets really interesting. Their diameter is directly related to the speed of neural transmission. The smallest axons might only transmit information at about 1 meter per second. That's roughly a slow walking pace. But the largest axons, they can transmit at a blistering 120 meters per second. Imagine a signal traveling the length of a football field in less than a second.
Wow, that's an enormous speed difference. What's the secret? How does some go so incredibly fast?
It's largely thanks to something called myelin. Imagine a well-insulated electrical wire. Myelin is this white, fatty substance that coats these longer, thicker axons, much like the plastic coating on an electrical cable. It acts as an insulator, preventing the electrical signal from leaking out and instead forcing it to jump along the axon in segments. This process, called saltatory conduction, it dramatically increases the speed and efficiency of neural transmissions. Without myelin, signals would leak and slow down considerably, making complex, rapid communication impossible. Conditions like multiple sclerosis, where myelin degrades, really highlight its critical importance.
So the brain truly has its own built-in high-speed internet cables, basically, all thanks to myelin. But this incredibly complex, delicate network also needs robust protection, right? Let's talk about the central command center's primary defenses, the skull and the meninges. The skull itself isn't just a simple uniform hard shell, is it?
No, it's far more intricate than that. The human skull is a bony enclosure made up of 8 separate plates that are intricately joined together by sutures. While it might appear roughly symmetrical from the outside, one half is often slightly larger than the other, and its structure changes significantly throughout life. For instance, an infant's skull plates are less firmly joined, making their skull more pliable and elastic, a characteristic mothers are undoubtedly thankful for during childbirth.
Right.
But as we age, that elasticity diminishes considerably and the bones fuse more rigidly. This is why an 80-year-old is significantly more likely to sustain a skull fracture from a blow to the head than a 20-year-old. The older skull is just more brittle.
That makes intuitive sense. And are some parts of the adult skull inherently more vulnerable than others?
Yes, definitely. The adult skull varies in thickness across its surface. It's surprisingly thin in the front and on the sides, often only maybe 3 to 5 millimeters thick. In contrast, the back of the skull, the occipital region, can be much thicker, sometimes as much as 15-20 millimeters. This structural difference explains why blows to the front or sides of the head are significantly more prone to causing fractures and underlying brain injury.
And beyond that bony shell, we have inner layers of protection, don't we? The meninges and the cerebrospinal fluid.
Precisely. The meninges are a system of 3 protective membranes that completely cover the brain and spinal cord. The innermost layer, called the pia mater, directly adheres to the brain's surface, following every single contour. And between some of these layers, specifically in the subarachnoid space, circulates the cerebrospinal fluid, or CSF. This fluid is absolutely crucial. It acts as a mechanical cushion, physically protecting the brain from sudden jolts and impacts, absorbing shock. But beyond that, it also plays a vital role in nourishing the brain tissue and removing metabolic waste products. Think of it as the brain's built-in shock absorber and nutrient delivery system, constantly circulating and refreshing.
So we have the individual neurons, these incredible high-speed cables, and then these layers of physical protection for the entire system. Now let's zoom out even further and look at the brain's surface itself, the cerebral cortex, with its distinctive ridges and grooves.
The cerebral cortex is truly the seat of higher function. It's where most of our complex thought, language, and perception happen. It's the thin, outer layer of gray matter that covers the brain, packed densely with billions of nerve cells. Its characteristic appearance, with all those folds and convolutions, is incredibly important. Those intricate patterns are made up of raised ridges, called gyri,
You're right, okay.
and the valleys or grooves between them, called sulci. The folding isn't just for aesthetics. It dramatically increases the surface area of the cortex, allowing more nerve cells to be packed into the limited space inside the skull. It's quite efficient.
And some of those grooves are so deep, they get a special name, right? They're like major geographical features on the brain's landscape.
They do indeed. The really deep sulci are called fissures. The 2 most prominent on the human brain, serving as critical anatomical landmarks, are the central fissure, also known as the fissure of Rolando,
Okay.
and the lateral cerebral fissure, often called the fissure of Sylvius. These fissures help divide the brain into its main functional regions.
And these landmarks help us divide each hemisphere into its main geographic and functional regions, the lobes.
Yes, traditionally, each hemisphere of the brain is divided into 4 lobes: the frontal, parietal, occipital, and temporal lobes. They're actually named after the skull bones that lie above them, which provides a convenient reference point. While their functions are incredibly complex and interconnected, generally speaking, the frontal lobe is heavily involved in higher-level cognitive functions like planning, decision-making, executing voluntary behavior. The occipital lobe is primarily responsible for processing visual information. The parietal lobe integrates sensory information from various parts of the body, and the temporal lobe houses the primary auditory cortex and is crucial for processing sounds, language comprehension, and memory. It's amazing how specialized yet interconnected these regions are.
It really is amazing how much specialized function is packed into such a small space, and all of it is utterly reliant on a constant, uninterrupted supply of blood. What happens if that blood supply is disrupted, even for a moment?
Well, the brain is an incredibly demanding organ, consuming a disproportionate amount of the body's oxygen and nutrients. A continuous flow of blood is absolutely essential. The impact of an occlusion or blockage of a cerebral artery depends critically on its location. If the blockage is in the main trunk or a primary branch of a cerebral artery, it will affect large regions of the brain, leading to widespread damage. However, if the blockage is in a smaller, more peripheral branch, it will impact a more localized and typically smaller area of brain tissue.
So it's a bit like a city's water supply. A break in the main pipe affects everyone, but a break in a smaller street pipe only affects a few blocks. And I understand there's a kind of backup system in some areas, watershed areas.
That's a great analogy. And yes, there's another fascinating aspect called watershed areas. These are specific regions in the brain where the distributions of major cerebral arteries slightly overlap at their outermost boundaries, forming a kind of border zone. What's interesting here is that occlusions at the periphery of an artery's distribution might cause less damage than one might expect. This is because there can be collateral blood supply from an adjacent artery. essentially a backup system, providing just enough blood to prevent extensive, irreversible damage. However, these watershed areas are also particularly vulnerable to conditions that cause a general reduction in overall blood flow to the brain, like severe drops in blood pressure, as they are the first to be deprived.
Connecting the dots, cranial nerves, and motor pathways.
Okay, building on our understanding of the brain's fundamental structures, let's talk about how the brain directly communicates with the specialized functions of the head and neck. That's where the cranial nerves come into play, right? They're like direct lines for senses and movements in our face, throat, and more.
That's an excellent way to think about it. There are 12 paired cranial nerves, labeled with Roman numerals I through 12 on each side of the central nervous system. Most of them originate and connect in the midbrain, pons, and medulla, which are parts of the brainstem. What's particularly fascinating is that cranial nerve F1, the olfactory nerve for smell, and cranial nerve 2, the optic nerve for vision, are actually unique. They're technically sensory tracts that project directly into the brain, above the brainstem.
Oh, interesting.
Yeah, and are considered extensions of the central nervous system itself, despite their traditional naming as cranial nerves since, well, ancient times.
So they're almost like brain tissue that extends out rather than typical peripheral nerves. And I understand each one pretty much controls specific functions on its own side of the body.
Precisely. Each cranial nerve controls specific muscle groups or receives sensory input from receptors on its respective side of the midline. This strict side-specific control is incredibly important when clinicians are trying to pinpoint the exact location of neurological damage. If a patient shows weakness on the left side of their face, for instance, it tells you the problem is likely with the left facial nerve or it's controlling structures in the brain.
Let's delve into a few specific cranial nerves that are particularly relevant to communication and often assessed in these disorders. How about the trigeminal nerve, CNV? How do clinicians test it, and what functions does it serve?
The trigeminal nerve, CNV, is a major player with both motor and sensory branches crucial for speech and chewing. To test the motor branch, a clinician might ask a patient to open and close their jaw against resistance or to clench their teeth tightly. Weakness in the jaw muscles or a jaw that deviates to one side when opening could suggest damage to this motor branch. For the sensory branch, they assess sensitivity to light touch, pain, and temperature across different regions of the face and anterior scalp. The sensory branch has 3 distinct divisions, the ophthalmic, maxillary, and mandibular, each covering specific areas, from the forehead down to the lower jaw. Testing these helps map any sensory loss.
Okay. And what about the glossopharyngeal CNIX and vagus CNX? I often hear them discussed together. Is there a reason for that?
They are indeed often discussed and tested together. This is because they frequently travel through the same small opening in the skull and share control of several crucial muscle groups in the soft palate, pharynx, and larynx, all vital for swallowing and voice. So if one is affected by injury or disease, the other often is too. Clinicians assess their motor functions by observing a patient swallow, looking for difficulties, and by observing the position and movement of their velum or soft palate, especially during speech or gagging. Injury to the glossopharyngeal nerve, for example, can cause the midline of the velum to be displaced away from the side of the injured nerve. Injury to the vagus nerve can lead to widespread dysfunction impacting both swallowing and voice. A specific and clinically critical concern is injury to the recurrent laryngeal nerve, which is a major branch arising from the vagus. Damage here causes weakness or even paralysis of the vocal fold on the same side, profoundly affecting voice quality, often leading to a breathy or hoarse voice.
So a problem with one of those could literally impact someone's ability to speak or swallow food. Wow, that's incredibly impactful. What about vision, the optic nerve, CN2, and how lesions along that pathway can cause very specific types of blindness?
Right. This is a classic example of how understanding neuroanatomy helps pinpoint problems. The visual pathway is quite complex, and damage at different points causes very specific visual field deficits. If a lesion completely destroys one optic nerve, the patient becomes blind in that specific eye. But if the damage occurs at the optic chiasm, that's a critical point where fibers from both eyes cross over. The patient might experience something called bitemporal hemianopia.
Bitemporal hemianopia.
Okay, yeah. This means blindness in the lateral or outer visual fields of both eyes, often forming a tunnel vision effect. It's frequently caused by tumors pressing on that crossing point. Now, if a lesion destroys the optic tract posterior to the chiasm or the visual cortex in one hemisphere, the patient will experience homonymous hemianopia. This is blindness in the visual half field on the contralateral side.
Opposite side.
Exactly, opposite side of where the brain damage occurred. So a lesion on the right side of the brain would lead to blindness in the left visual field of both eyes.
It's truly like a neurological map, where the type of visual loss dictates exactly where the damage occurred. Fascinating. Shifting gears to movement, how does the brain orchestrate all our voluntary actions, from picking up a pen to complex speech? What are the key motor pathways involved?
Voluntary movement is orchestrated by several crucial descending fiber tracts that originate from various levels of the brain, the cerebral cortex, midbrain, and brainstem, and connect to motor neurons at lower levels in the spinal cord or brainstem. The corticospinal tract, for instance, is a major pathway. It begins in the cerebral cortex and descends all the way to motor neurons in the spinal cord. This tract is primarily responsible for the volitional movement of your trunk and limbs, literally, the brain telling your arms and legs what to do when you consciously decide to move.
What about for talking, chewing, making facial expressions, all those head and neck movements so crucial for communication?
For those, we have the corticobulbar tract. Similar to the corticospinal tract, it also originates in the cerebral cortex, but it connects with motor neurons in the brainstem. This tract is responsible for the volitional movement of muscles in the head and neck, controlling everything from chewing and swallowing to facial expressions and the intricate movements of the tongue and lips necessary for speech. Beyond conscious volitional movement, we also have other important tracts like the vestibulospinal tract, which plays a critical role in quick reflexive movement in response to sudden body position changes, like when you suddenly lose your balance.
Right, catching yourself.
Exactly. And finally, the descending autonomic tract modulates essential involuntary autonomic functions like regulating your heart rate and blood pressure, mostly without conscious thought. It's an incredibly sophisticated system, handling both deliberate actions and rapid, life-sustaining reflexes.
The neurologic detective. Assessment and diagnosis of communication disorders.
Given the incredible complexity we've just explored, from the microscopic neuron to the vast motor pathways, becoming a neurologic detective seems like a formidable task. How does a clinician even begin to piece together the puzzle of a communication disorder when there are so many potential points of failure?
It absolutely is a complex puzzle, but clinicians follow a systematic and iterative approach, much like a scientific investigation. The neurologic examination typically begins with a thorough patient history. This is crucial. It involves interviewing the patient and their family members, if possible, to understand their symptoms when they first appeared, how they've changed over time, and what functional difficulties they are experiencing. This initial narrative provides invaluable clues and helps narrow down the possibilities.
And after that crucial initial conversation, what's next?
Then the clinician moves into a more objective evaluation, assessing the patient's motor status, sensory status, and mental status. These are the core areas of assessment. Based on the findings from these evaluations, combined with the patient history, the physician may then order specialized laboratory tests or imaging studies. These are essential for answering any unresolved questions about the precise nature, location, and severity of abnormalities within the nervous system. For example, an MRI can show brain lesions, while a blood test might rule out something else.
So they're looking for objective evidence to confirm or clarify their suspicions. Okay. When it comes to motor impairments, what are some of the common complaints patients voice, and what do those complaints suggest about where the damage might be?
Patients often present with very specific complaints that act as critical clues. They might report general weakness on one side of the body, or weakness localized to an arm, hand, finger, or leg. Some complain of frequent falling, clumsiness, or stiffness. Difficulty initiating movement, tremors in the hands, excessive fatigue, double vision, or slurred speech are also very common indicators. What's fascinating here is how these complaints can point to potential damage in specific brain regions. For instance, general weakness often suggests issues in the motor cortex or its descending pathways. Clumsiness, especially with slurred speech, might indicate cerebellar damage.
The cerebellum for coordination.
Right. Stiffness and difficulty initiating movement, perhaps with tremors, often point to damage in the basal ganglia, those deep brain structures. And if someone complains of excessive fatigue or double vision, it can sometimes suggest problems with nerve muscle junctions, like in myasthenia gravis. Each symptom is like a breadcrumb.
So the symptoms are like breadcrumbs leading to the affected area. What about when you physically examine a patient's muscles? What are muscle tone abnormalities telling you?
Assessing muscle tone is a critical part of the examination. Hypotonia, or flaccidity, refers to a decreased resistance to passive movement. If you move a patient's limb, it might feel unusually floppy, what's sometimes called the ragdoll phenomenon, and their tendon reflexes are usually diminished or absent. While general hypotonia can occur in many diseases, hypotonia specifically in the distribution of a cranial or spinal nerve almost always signifies damage to that particular peripheral nerve or its nucleus in the brainstem or spinal cord.
And the opposite, spasticity, what does that indicate?
Spasticity is a stark contrast and indicates a very different type of damage. It occurs when there's damage to upper motor neurons, meaning the lesion is in the brain, brainstem, or spinal cord, above where the nerve fibers cross over, or decussate. Spasticity is characterized by hyperreflexia, meaning exaggerated or brisk tendon reflexes, and hypertonia, which is increased muscle tone causing stiffness and resistance to passive movement, often described as clasp knife rigidity.
So if someone has a brain injury, that tells you something about the kind of motor impairment they might have. This leads us to a truly critical distinction in neurology: upper versus lower motor neuron damage. How do these two types of damage differ in their effects on the body?
This is a fundamental concept that helps clinicians localize neurological problems. Damage in upper motor neurons, those originating in the brain, brainstem, or spinal cord, above the fiber decussation, typically causes contralateral motor impairment.
Contralateral meaning opposite side.
Exactly. The weakness or paralysis appears on the opposite side of the body from where the damage occurred. For example, a stroke on the left side of the brain would affect the right side of the body. The affected muscles usually involve large muscle groups, maybe even all the muscles on one side, and they are typically spastic, hyperreflexic, and hypertonic, as we just discussed.
So a left brain stroke causes right-sided weakness and the muscles are stiff.
Precisely. Conversely, damage in lower motor neurons, the cranial or spinal nerves themselves, after they've exited the brainstem or spinal cord, produces ipsilateral hypotonia and weakness or flaccid paralysis. Ipsilateral means it affects the same side of the body as the nerve damage. For example, damage to the facial nerve, CN7 on the left side, causes flaccid paralysis only in the muscles of the lower left side of the face. The key difference: upper motor neuron damage affects large muscle groups with spasticity, often contralaterally. Lower motor neuron damage causes flaccid weakness in individual muscles, ipsilaterally.
And sometimes there are these odd involuntary movements that can give clinicians clues. What are some of the common ones?
Yes, there are several distinct types. Dystonia refers to sustained, often twisting and repetitive, involuntary contractions of muscle groups, leading to abnormal postures or repetitive movements. Imagine a prolonged spasm distorting a limb. Then there's myoclonus, which describes abrupt, rapid, non-rhythmic, single-jerk twitching movements. These can sometimes be large enough to cause visible limb movements, like a sudden leg jerk. And finally, fasciculations are rapid, irregular, small twitching movements of small groups of muscle fibers. They don't cause overt limb movement, but can be seen as subtle dimpling or rippling of the skin over the affected muscles, often indicating irritation of the lower motor neuron.
Fascinating how the body's involuntary movements can provide such specific diagnostic information. Shifting to sensory insights, how does the brain process sensations like pain, temperature, and touch, and what happens when those pathways are damaged?
Sensation is primarily conveyed by specific tracts in the spinal cord. The spinothalamic tract, for instance, is responsible for transmitting pain and temperature sensations from the body up to the brain, specifically the thalamus and then the cortex. What's particularly insightful here, clinically, is a neurosurgical procedure called a chordotomy. This is where a neurosurgeon cuts fibers in a patient's spinothalamic tract, usually as a last resort, to relieve intractable severe pain. A known and predictable side effect is that the patient also loses temperature sensation below the level of the cut, providing direct evidence of the tract's function.
So a targeted intervention for pain has a very specific sensory side effect, confirming the pathway's function. That's interesting.
Exactly. Another condition that reveals much about these pathways is anterior myelopathy. This is pathology specifically affecting the anterior part of the spinal cord, often due to an occlusion of the anterior spinal artery that supplies it. It typically leads to a bilateral loss of pain and temperature sensation below the lesion, a subtle impairment of light touch on both sides, and often paralysis below the lesion because it impacts both spinothalamic and corticospinal tracts.
And how do clinicians map where a sensory impairment is to narrow down which specific nerve is affected? Dermatomes.
That's where dermatomes come in. Dermatomes are specific regions of skin that are innervated by a particular cranial or spinal sensory nerve. Each spinal nerve, for example, serves a specific band of skin. By precisely mapping where a patient experiences a loss or change in sensation, say numbness in a particular band around the trunk, and matching that pattern to a known dermatome chart, the examiner can pinpoint which specific nerve root is affected. It's a crucial way to localize peripheral nerve damage, like using a detailed anatomical map.
So, the body itself provides a map for diagnosis. Beyond sensation, issues with balance and gait can also be highly indicative of neurological problems. What do clinicians look for when assessing these, and what's Romberg's sign?
Patients experiencing disequilibrium or a sense of unsteadiness often show specific patterns. They might stand with their feet wide apart to increase their base of support, be reluctant to stand with feet close together, and may even be unable to bring their feet completely together without falling. Romberg's sign is a key clinical test here. For patients whose disequilibrium is caused by a loss of proprioceptive feedback, that's the sense of where your body is in space, from the legs and feet, they often compensate by relying heavily on visual input to maintain balance. So when these patients close their eyes, removing that visual compensation, they become increasingly unsteady and may even fall.
And that's different from, say, a cerebellar problem, which also affects balance.
Yes, it is a crucial differentiation. Patients with cerebellar pathology, affecting the cerebellum which coordinates movement and balance, will typically be unsteady whether their eyes are open or closed. However, their unsteadiness might worsen slightly with eyes closed. The key difference is that Romberg's sign specifically points to a sensory deficit in proprioception, where the patient uses vision to compensate, whereas cerebellar ataxia is a primary motor coordination problem. The way someone stands or falls can really point to a specific part of the nervous system.
That's incredible. Now, in the modern age, we can literally see inside the brain and measure its activity. Let's talk about the array of imaging and electrophysiology procedures available to these neurologic detectives.
Indeed, technology has revolutionized neurological diagnosis. For traditional structural imaging, we have procedures like basic X-rays, historically called skull films, though these are now largely supplemented by more advanced techniques. Myelography is a specialized X-ray procedure where contrast dye is injected into the spinal canal to visualize the spinal cord and its surrounding space, useful for detecting structural changes like tumors or disc herniations.
And computed tomography, CT, and magnetic resonance imaging, MRI scans. Those are widely known.
Right. Computed tomography, or CT scanning, is an X-ray procedure producing cross-sectional slices of internal structures. It creates images based on how much resistance different tissues offer to X-rays. Bone appears very bright, brain tissue gray, CSF dark. Magnetic resonance imaging, MRI, produces images based on the chemical composition of tissues, particularly their water content, using strong magnetic fields and electromagnetic energy. MRI offers significantly greater detail for soft tissues like the brain and is excellent for detecting subtle lesions, making it a gold standard for many neurological conditions. And angiograms are specialized X-rays, using contrast medium injected into the bloodstream to visualize blood vessels. These are incredibly useful for detecting occlusions, blockages, or stenosis, narrowings of arteries, as these areas simply won't fill with the contrast dye. You can see the intricate network.
So those let us see the structure of the brain and its plumbing, but what about actually measuring brain activity, not just structure, but function in real time?
For that, we turn to electrophysiologic procedures, like the electroencephalogram, or EEG. This is where electrodes placed on the scalp record the electrical activity generated by the cerebral cortex. The distinct wave patterns and any anomalous activity, like the characteristic spike in wave patterns seen in petit mal epilepsy compared to a normal EEG, help clinicians infer what's happening physiologically in the brain's electrical landscape.
And then there's functional brain imaging, which sounds even more advanced, like PET and fMRI.
They are indeed. Positron emission tomography, PET, was one of the first techniques to visualize metabolic activity. It involves introducing a metabolically active material, usually a glucose analog tagged with a radioactive isotope, into the body. This material concentrates in brain regions with high metabolism and neural activity. As the isotope decays, it emits positrons, then photons, which are processed into images showing regional metabolic activity, essentially, where the brain is working hardest. Functional MRI, or fMRI, has largely dominated functional imaging recently due to its low invasiveness and no radiation exposure. It detects subtle changes in oxygen-rich hemoglobin, which naturally increases in neurally active tissue due to increased blood flow. This allows it to produce these almost photograph-like images of brain activity as it's happening, showing us where the brain is processing information in real time. Invaluable for research.
So we can see structure, electrical activity, and even where the brain is metabolically active. And sometimes to analyze the actual fluids around the brain, a lumbar puncture or spinal tap is done. What's the purpose of that?
A lumbar puncture, often called a spinal tap, is a procedure performed when infection, inflammation, or hemorrhage in the central nervous system is suspected. A thin needle is inserted into the subarachnoid space in the lower lumbar spine, well below the end of the spinal cord, to safely take a sample of cerebrospinal fluid, CSF, for analysis. The pressure with which the fluid flows is also measured, as increased pressure can suggest blockages in CSF circulation, a tumor, or swelling of brain tissue, all critical diagnostic clues.
It's truly a testament to medical science how many sophisticated ways there are to investigate what's happening inside the skull. So, pulling all this together, it sounds like arriving at a diagnosis isn't just a simple checklist, but more like a scientific method in itself.
It absolutely is what we call an iterative process, mirroring the scientific method. As each piece of information about the patient becomes evident from history, records, interviews, tests, the clinician constantly evaluates its meaning, looks for relationships, considers alternatives. This process of selection and elimination continues, refining the understanding until the most compatible and accurate diagnosis is reached. It's not about finding one smoking gun, but assembling a complete picture.
And it's not some innate magical art that only a few possess, is it? It's learnable.
Oh, no, it's very much a learnable skill. Proficiency in this clinical diagnostic method can be significantly improved by consciously and systematically considering the meaning of each piece of information. It's a rapid dynamic cycle, constantly adapting as new facts emerge, allowing the clinician to rule out alternatives and converge on the most accurate picture. The more you practice this systematic approach, the better you become.
The mind's labyrinth. Cognitive and communication impairments.
So we've navigated the intricate landscape of the brain, its protective layers, and how clinicians play detective. Now, let's venture into the mind's labyrinth and explore how brain injury can manifest in altered mental states, often going beyond just simple forgetfulness. What does confusion truly mean in a clinical sense, and what causes it?
Clinically, confusion, often referred to as delirium or an acute confusional state, means a patient has impaired orientation, they struggle with knowing where they are, what day it is, maybe even who they are, even if their level of consciousness is normal or only slightly lowered. What's crucial, and often surprising here, is the incredibly wide range of causes. It can stem from something seemingly simple, like nutritional deficiencies, or more serious issues like drug or alcohol intoxication, infections, head trauma, fever, or even initial stages of a dementing illness. It's a very common presentation in acute care.
So it's not always a permanent state, but rather a temporary disruption that can clear.
Exactly. It's often transitory. A period of acute confusion might clear as the underlying cause is treated or resolves, leaving the patient with a more specific, longer-lasting deficit, like a language impairment from a stroke, once the acute confusion clears up. It's a very generalized disruption that often precedes or accompanies more focal problems.
Speaking of focus, attention is often described as the brain's limited spotlight. What does that mean from a cognitive perspective, and why is it so fundamental to all other cognitive processes?
It refers to the resource allocation model of attention, a core concept in cognitive psychology. The idea is that our brains have a finite, limited pool of mental resources available for carrying out all our various cognitive operations, everything from listening to this deep dive to planning your day. The more complex the task, or the more tasks we try to do simultaneously, the more resources are drawn from this finite pool. If the demand for these resources exceeds what's available, our performance inevitably deteriorates. You simply can't do everything perfectly at once if your resources are stretched too thin.
And what happens with a brain injury in that model?
Yes.
Does the pool itself shrink, or is it harder to access? That seems like a really important distinction.
That's still an ongoing question and a major area of research. We don't definitively know whether a brain injury actually reduces the total amount of available cognitive resources, or if it primarily compromises our ability to access those resources efficiently, even if the pool theoretically remains the same size. Regardless, the functional outcome for the patient is often a significantly reduced capacity to manage complex or multiple tasks. It highlights the intricate nature of attention.
Regardless, the outcome is reduced capacity. Solberg and Mateer, key figures in this field, propose 5 distinct categories of attention. Can you walk us through them? They really illustrate the multifaceted nature of this core ability.
Certainly. These categories provide a crucial framework for understanding the different facets of attention that can be affected. First, there's focused attention, sometimes called orienting. This is the most basic level. Simply the ability to physically orient to a sensory input, like looking toward a sound or turning when touched. Second, sustained attention. This is maintaining attention over time, especially during repetitive tasks, like monitoring a screen or staying focused during a long lecture. Third, selective attention is maintaining attention amidst competing or distracting stimuli. Think concentrating in a noisy room or doing a cancellation task where you find specific items among others. The Stroop test is a classic example assessing this.
Right, naming the color, not the word.
Exactly. For alternating attention involves flexibly shifting attention between different stimuli or task requirements, like cooking multiple things at once, or doing serial calculations alternating addition and subtraction. And finally, often implied as the highest level, divided attention represents performing multiple tasks simultaneously, truly splitting your attentional resources, like driving while talking, hands-free, of course.
It's clear that attention is far more complex than just paying attention. What about memory? Beyond simple recall, what are the different stages or types of memory, and how do clinicians assess impairments across them?
Most multi-stage models start with the sensory register, or sensory memory. This is the initial fleeting stage where incoming sensory information is briefly retained, maybe 1 to 2 seconds, in a modality-specific form. For auditory stimuli, it's echoic memory, the echo of what you just heard, and for visual, iconic memory, the fleeting image. It has a large capacity but very short duration, like a raw snapshot.
So it's like a fleeting snapshot or echo, just long enough for your brain to decide if it's important.
Exactly. The second stage is immediate memory, also known as short-term or primary memory. This has a much more limited capacity, and information here decays in a few seconds unless it's actively rehearsed. Its capacity is often quantified as retention span, which for normal adults is typically around 7 plus or minus 2 items. That's why remembering a new phone number is challenging without writing it down.
Right, the classic 7 plus minus 2. And the third, implied stage, is long-term memory, where information is more permanently stored. How do clinicians assess impairments, especially beyond simple number recall?
For assessing memory impairments beyond immediate span, clinicians use superspan retention tests. In these, the examiner reads a list of words exceeding the patient's immediate span, maybe 15 words or more. They then ask the patient to recall as many as they can, repeating the list over multiple trials until a patient either learns it or for a set number of trials. Tests like the Auditory Verbal Learning Test or California Verbal Learning Test assess how much information a patient can learn and retain over repeated exposures.
And in the context of traumatic brain injury, TBI, there's specific terminology for memory loss related to the injury itself, isn't there? Not just general amnesia.
That's right. For TBI, we talk about pre-traumatic memory loss and post-traumatic memory loss. These terms have largely replaced the older retrograde and anterograde amnesia. Pre-traumatic memory loss refers to the period immediately preceding the injury for which a patient has no recollection. The loss for seconds, minutes right before is thought to be caused by disruption of the neurochemical processes for encoding memory at the moment of impact. Post-traumatic memory loss refers to the period after the injury where the patient also has no recollection. Measuring the duration of post-traumatic memory loss is a key indicator of TBI severity.
So memory is a very active, multi-stage process, easily disrupted. And if memory is about storing and retrieving, executive function sounds like the brain's overall management system. What are its core components and why is it so crucial for daily life?
That's a perfect analogy. Executive function encompasses a whole suite of underlying cognitive processes, allowing us to plan, organize, and execute goal-directed behavior. It's the brain's conductor, coordinating things like attention, memory, response flexibility, planning, reasoning, problem-solving, and abstract thinking. Conclusions about executive function are often drawn from performance on tests tapping these processes and how they apply these skills in real-world scenarios. It's what allows you to adapt and solve new problems.
And you mentioned response flexibility. What does that look like when it's impaired? It sounds like it could be very debilitating.
Some brain-injured patients struggle significantly with response flexibility. They might initiate a behavior okay, but then find it incredibly difficult to inhibit, modify, or stop it, even if it's no longer appropriate. They can appear trapped by first impressions, unable to adapt to changing tasks. For example, if you ask them to sort cards by color, then change the rule to shape, they might persist sorting by color despite feedback. This perseveration can be very challenging.
So, it's about adaptability. How do clinicians assess something complex like planning, which involves multiple steps and foresight?
Planning can be assessed with tasks like cancellation tests or more complex trail-making tests. In these, a patient connects sequences of letters or numbers in order or alternates between them scattered on a page. Maze tests also assess planning, requiring drawing a line from start to finish without crossing boundaries. Both require maintaining a mental representation for seeing dead ends and monitoring progress. Increasing complexity reveals deficits.
And reasoning and problem solving. Are there specific tests for those higher level abilities?
Yes, picture arrangement tests ask patients to arrange scrambled pictures into a logical story. Picture absurdities tests require identifying what's illogical in bizarre images, like a car on water. For nonverbal assessment, useful for language impairments, the standard progressive matrices and colored progressive matrices tests are often used. These are multiple choice tests, choosing a missing part of a visual pattern, assessing visual spatial analysis, integration, and abstract reasoning without verbal responses.
What about abstract thinking? That seems particularly complex and hard to measure objectively.
Abstract thinking, grasping concepts beyond the literal, can be assessed in several ways. One common method is asking patients to explain similarities and differences between words, like, how are a table and a chair alike? Another powerful approach involves categorization and sorting tests, like the widely used Wisconsin card sorting test, or WCST. Patients deduce rules for sorting cards based on right or wrong feedback. The test then changes the rule without warning, forcing them to adapt and find a new sorting principle, assessing conceptual flexibility.
These sound quite ingenious, directly measuring these high-level functions. Are there tests that try to assess executive function more directly by simulating real-life situations?
Yes, there are specialized procedures designed to do just that. The Six Elements Test, SCT, has 6 open-ended tasks requiring initiation, planning, problem-solving, and monitoring, often with time constraints. Another is the Executive Route-Finding Task, where the patient finds a place in a facility and an observer rates their understanding, information use, and error detection in a naturalistic setting. While these have high content validity, they assess what they claim to put. They pose challenges to reliability because the exact conditions, like distractions, are hard to replicate consistently.
So very realistic, but tricky for consistent measurement. Finally, let's talk about the emotional and psychological effects of brain injury. I've heard of emotional ability. What is that and how does it manifest?
Emotional ability is a condition where brain injury contributes to exaggerated swings in emotional expression that seem out of proportion to the situation. Patients express sadness or happiness appropriately, but their response is disproportionately intense or excessive and often uncontrollable. It might appear as uncontrollable crying to neutral stimuli. A patient might cry when asked if they have children. Or it can be inappropriate or excessive laughter, especially when stressed or frustrated. It's not necessarily that they feel more intense emotions, but their ability to modulate the outward expression is impaired.
And is there a specific neurological reason for this kind of disinhibition, pseudobulbar effect?
Yes, neurologists sometimes refer to this as pseudobulbar effect because it's commonly seen after bilateral damage to the corticospinal and corticobulbar tracts. When these tracts are damaged, particularly above the pons, it can represent a loss of cortical inhibition over more primitive emotional responses originating in lower brain structures. The cortex, which usually modulates these expressions, isn't providing that dampening effect, leading to these exaggerated displays.
Assessing language, the nuances of communication impairments.
It's clear that brain injury can profoundly impact a person's cognitive landscape. Now, let's shift our focus to communication itself and the critical role of the speech-language pathologist. What are their core functions in this complex process?
Speech-language pathologists play a multifaceted and absolute central role. Their core functions include accurately diagnosing communication impairments, providing a prognosis for recovery, determining the specific nature and severity of impairments, identifying strengths and weaknesses, making informed decisions about treatment, and then continually measuring recovery or assessing the efficacy and effectiveness of treatment. It's an ongoing process.
So it's not just about slapping a diagnostic label on someone.
Exactly. While diagnostic labels like aphasia are convenient shorthand, they don't in themselves directly dictate the precise treatment plan. They provide a general framework, but specific treatment is always highly individualized, based on a detailed understanding of the patient's unique profile. A label tells you what category, not necessarily how to treat.
Let's unpack how an SLP assesses specific language abilities, starting with auditory comprehension. Are initial screening tests typically enough?
Screening tests are useful as an initial quick check, but few have strong enough psychometric properties, reliability, and validity to truly capture the precise presence or absence of specific impairments with high confidence. They're a starting point indicating the need for more comprehensive evaluation.
So for single-word comprehension, how is that assessed, and what are the subtle nuances that can affect performance?
Single-word comprehension is typically assessed by asking patients to point to objects or pictures as they are named, or match spoken to written words. Interestingly, for most brain-injured adults, whether items or objects or pictures doesn't strongly affect performance, though those with visual issues might prefer real objects. A crucial factor and a common source of error for people with aphasia, PWAs, is similarity between target words and foils. Semantic similarity, foils related in meaning, like mother for father, is a far more frequent source of confusion than acoustic similarity, time for time. This tells us difficulty is often semantic processing, not just hearing. Also, the part of speech can affect comprehension, varying individually.
That's a good example of subtle factors. What about sentence comprehension? That seems like a significant jump.
It is. Sentence comprehension is often assessed using gestural or manipulative responses to spoken instructions like, take this paper, fold it, give it to me, or yes, no questions. A common test is the token test, using color-shaped tokens and commands of increasing complexity. A crucial clinical tip. Co-occurring conditions like Apraxia or temporal sequencing impairments could affect performance, looking like comprehension issues when it's motor planning. So examiners might cover visual arrays to ensure auditory-only comprehension.
And in real life, we rarely hear isolated sentences. Does that real-world context play a role in assessment?
It plays a huge role. Daily life rarely presents decontextualized single sentences. Listeners constantly use context heuristic processes or top-down processing, use world knowledge, experience, situation to anticipate meaning. Single-sentence tests remove this crucial support, making it artificially harder for brain-injured listeners who rely heavily on context. So poor performance on a test doesn't mean they won't understand more in a natural conversation.
So we naturally fill in the blanks. When we move to understanding a larger narrative, like a story, what's the difference between narratives and expository prose, and why does it matter?
Narratives, or story-like texts, are generally easier for both brain-injured and normal listeners than expository paragraphs, which are more fact-based and often require recall of specific details like names, dates. Narratives have predictable structure, engage world knowledge. What's consistent, though, is that main ideas are reliably comprehended and remembered far better than isolated details, for everyone.
And heuristic processing, top-down processing, how does that tie into understanding a whole narrative?
Heuristic processing is critical for discourse. It's using world knowledge and experience to make informed guesses about meaning and structure, guiding lexical and syntactic analyses, letting us quickly grasp the gist. Speakers' writers also make important information salient, stand out through repetition, elaboration, paraphrase, introductory phrases. This helps listeners, especially those with difficulties, identify main ideas.
So what kinds of stimulus manipulations can clinicians use in treatment to adjust difficulty, making tasks more accessible?
Clinicians have several powerful tools. One is rate of speaking. Slower rates, like 120 words per minute versus 150 plus A, are significantly beneficial for aphasic listeners, giving more processing time. Pause insertion, deliberate pauses at syntactic boundaries also help segment information. Alerting signals like ready, listen, prepare the listener, and emphatic stress, extra prosodic emphasis on important words aids comprehension. What's often most effective is combining slow rate with exaggerated stress. It highlights the importance of how we deliver information.
That's a fantastic practical tip. Beyond listening, reading and writing are also critical. What does reading actually entail beyond just seeing words?
This is definitely more than just visual perception or sounding out. Letter or word matching tests primarily assess visual perception, and oral reading converting graphemes to phonemes can be done perfectly without comprehension. Someone can read aloud perfectly without understanding a word if semantic access, meaning, isn't achieved. True reading involves deriving meaning.
So there are different levels of reading comprehension that need assessment.
Absolutely. Clinicians assess across increasing levels. First, single words, matching printed words to picture-spoken words. For sentences, responding to printed yes-no questions, completing sentences, following instructions. For longer printed texts, reading short passages, narratives easier than expository, and answering questions. And importantly, functional reading, understanding signs, labels, menus, forms, using tests like the RCBA-2 to see if they can navigate everyday print.
And for those who struggle with reading, are there different types of dyslexia revealing different pathways?
Precisely. Two classic types are deep dyslexia and surface dyslexia. Individuals with deep dyslexia have impaired indirect phonologic routes. They struggle to sound out words, especially non-words. They rely more on the direct whole word route. Result: semantic errors. Reading chair, his table. Conversely, surface dyslexia involves an impaired direct whole word route. They rely heavily on the indirect grapheme to phone route, sounding words out. So they struggle with irregularly spelled words like yacht or kernel because sounding them out phonetically fails.
That's a clear distinction. What factors generally affect printed sentence comprehension beyond decoding?
Similar to spoken sentences. length, syntactic complexity, redundancy. Additionally, difficulty converting graphemes to phonemes impacts sounding out. There's less extra-linguistic support, no pauses, gestures, intonation. And many readers tend to overlook or misread small but crucial function words like to, by, of, altering meaning.
Are there objective ways to measure text difficulty to ensure materials are appropriate readability formulas?
Yes, readability formulas quantify reading difficulty. Most calculate a grade level based on sentence length, words per sentence, and vocabulary difficulty, syllables per word. Useful as a general guide, but don't capture all complexities.
And finally, writing. How is impaired writing or agraphia manifested, and how is it typically treated?
Agraphia or dysgraphia refers to acquired writing impairments. Often writing merely spoken empty speech or errors lacking content words, poor grammar, spelling. Most PWAs have significant spelling syntax issues. Treatment focuses on these. Spelling, syntax, grammar, often using a didactic teaching approach with structured homework and repetitive practice. It's often direct re-education.
So from comprehension to production, across modalities, it's very layered assessment. Now, speech production itself, moving from isolated words to connected discourse, how are those measured?
For speech production, various methods. Repetition tests are fundamental, repeating syllables to complex sentences, difficult for many brain-injured patients. Naming tests assess word retrieval. Confrontation naming is naming picture subjects. Responsive naming is one-word answers, what color is snow. And generative naming, word fluency measure, is saying as many words as possible, starting with the letter F, A, S, or category animals in a time limit.
What about those moments struggling to find a word? What do word retrieval failures look like?
Word retrieval failures, anomia, are very common. Manifest as long delays, repeated attempts, self-corrections. Patients might substitute related words, verbal paraphasia, or sound-related words, literal paraphasia. What's sometimes counterintuitive is that for some, being given semantically related words as pre-stimulation, like something you sit on, can actually worsen retrieval, possibly creating more competition in the lexical system.
That's surprising. And when we move to continuous speech, discourse production, telling a story, how is that quantified beyond just counting words?
For discourse, we measure communicative efficiency, informativeness, percentage of words conveying new info, and content units per minute, rate of relevant info production. We also know performance deviations, qualitative aspects like inaccurate or unintelligible responses. Standardized tasks like story retell procedures, SRP, use predefined stories equated on linguistic variables for comparison. We can even measure syntactic complexity using TNITs.
Precise tools for breaking down natural language flow. And to bring it all together, what are some key standardized language test batteries SLPs use for that comprehensive picture?
Several comprehensive batteries. The Porch Index of Communicative Ability, PICA, is detailed, unique for its 16-category scoring and diacritic markings providing descriptive results. Requires training for reliability but yields rich data. Then there's the Boston Diagnostic Aphasia Examination, BDAE3, comprehensive, compares performance to a large group, helps classify into neurodiagnostic aphasia syndromes, though many patients don't fit perfectly.
And the Western Aphasia Battery, WAB, how does that fit in?
The Western Aphasia Battery, WAB, is generally shorter, psychometrically sophisticated, emphasizes classification into classic syndromes, Broca's, Wernicke's, based on spontaneous speech, auditory comprehension, repetition, naming. Includes subtests for reading, writing, apraxia, constructional visual spatial calculation abilities, providing a broad overview. These batteries are crucial for objective measurement.
It's clear, comprehensive, objective testing is crucial. But how does detailed impairment assessment translate into real-world benefit? That brings us to beyond impairment, functional outcomes, and quality of life.
Beyond impairment, functional outcomes and quality of life.
So when it comes to treatment, there's been a crucial shift from focusing just on efficacy to emphasizing effectiveness. Can you explain the difference and why it matters so much?
This distinction is paramount. Efficacy asks, does treatment yield significant change on tests beyond no treatment in controlled settings? It's about whether it works under ideal conditions. Effectiveness, however, asks, does treatment cause meaningful changes in relevant daily life tasks or overall communication in the patient's natural environment? Does it help a doctor write a prescription again? Improve social conversations? While evidence supports efficacy for many treatments, the current focus is squarely on effectiveness because that's what truly impacts daily life, independence, and often what funding sources prioritize.
So it's about real-world impact, not just a test score. How do clinicians measure these functional outcomes, these real-world changes?
Program evaluation often relies on rating scales. abilities rated at entry, and exit judge program quality. However, some scales, like the Functional Independence Measure, FIM, are quite global and can be insensitive to small communication changes. The FIM is widely used in rehab for basic ADLs like eating dressing, but criticized for poor reliability capturing communication changes, even though it's a principal outcome measure.
So it might tell you if someone can walk, but not hold a meaningful conversation.
Exactly. To address this, AHA developed the AHA Functional Assessment of Communication Skills for Adults, AHA-FACS. This tool rates communicative adequacy across 4 domains: social communication, basic needs, daily planning, and reading-writing number concepts. It uses a 7-point scale of communicative independence, does with no assistance to does not do. This gives a much more specific, relevant view of real-world communication function.
That sounds much more specific. And beyond functional tasks, what about overall quality of life? How is that assessed, especially when communication, so central to connection, is impaired?
Quality of life is profoundly important. One early detailed instrument was the Sickness Impact Profile, SIP. 136 statements, physical psychosocial domains. Major disadvantage length. Takes 30 minutes for unimpaired people, impractical for many.
Definitely not ideal for someone with cognitive challenges.
Precisely. A more practical, widely used option is the WHO Girl Breath from the World Health Organization. Shorter, 26 items across physical, psychological, social, environmental domains. Much more feasible clinically.
But assessing quality of life, so subjective, must be particularly challenging for brain-injured individuals with impaired self-awareness.
It is a significant challenge. Getting accurate self-reports is complicated by potential problems with comprehension, attention, judgment, altered self-perception, or anosognosia. Many simply cannot reliably respond. While proxy respondents' family members are often used, the validity of their responses for assessing a patient's personal feelings hasn't been fully established. Can family truly speak to someone else's internal experience? It's debated.
So, to try and address that, was there a specific measure developed for people with language impairments?
Yes. Recognizing that need, the Communication Quality of Life Scale, QCL, was designed precisely for persons with significant language impairments. It has short, grammatically simple statements about communicative aspects, I like to talk to people, and participation, my role in the family is the same. Its simplicity aims to minimize effects of language impairment on self-report.
It's clear all these assessments are complex. What's the essential takeaway about the need for comprehensive assessment?
The message is clear. Forming an accurate diagnosis, confident prognosis, and effective treatment plan requires much more than quick screening, family impressions, or informal chats. It necessitates periodic, objective, comprehensive testing. We simply cannot rely on cursory assessments for critical decisions about recovery or treatment effectiveness. It's the foundation.
A powerful statement. This brings us to the path to recovery, treatment structure, and ensuring generalization, applying clinic learning to the real world.
The path to recovery, treatment, and generalization.
So, knowing all that goes into assessment, let's talk about the modern approach to care, which sounds like it's far from a solo endeavor. What is a treatment team, and who are the key professionals involved? Why is collaboration crucial?
Modern care is indeed managed by a true treatment team. Responsibility rests with a collaborative group, though one member, often a physician or case manager, coordinates. Composition depends on need stage. For stroke rehab, it might include a neurologist, rehab nurse, SLP, neuropsychologist, physical therapist, PT, occupational therapist, OT, dietitian, social worker. Each has primary responsibility, but roles often overlap, making consistent communication crucial.
Sounds like a lot of experts. Who are the physiatrists and what's their specific role?
Physiatrists are rehabilitation medicine physicians. They have primary medical responsibility in rehab settings, overseeing the entire plan. They focus on helping patients regain muscle function or compensate for impairments through strategies equipment. They essentially design and oversee the comprehensive program.
And the speech-language pathologist in this collaborative team, what's their unique contribution?
The SLP plays a prominent, often central part, especially with cognitive communicative disorders, given their expertise in assessment, treatment, and crucially, communicating with these individuals. They provide assessment, treatment, referral for communication swallowing. A key role is communicating patient family needs and progress to the team, acting as a vital link and advocate.
Truly collaborative. When guiding treatment, how do they individualize? What factors influence whether a patient will benefit?
Several variables influence benefit: the nature and severity of the brain injury, patient's overall medical physical status, and perhaps most importantly, their motivation. Often a few sessions of trial treatment can be the most dependable indicator of how a patient will respond, gives a real-world sense of potential.